Dr. Duane Anderson. I practiced for the last 19 and a half years in Soto, Ethiopia. And I just want to share with you a low complication, high success surgical treatment of tibial plateau fractures that we've developed in Ethiopia. Okay, so what determines a great result in a tibial plateau fracture? Number one, you want a smooth articular surface. Number two, you want the overall limb alignment to be neutral. Varus and valgus has been proved to reduce the overall final result. Obviously, you want great knee motion and you want a stable knee. And the thing that we're really going to center in on today is avoidance of a major complication like infection in the path to fixing your fracture and treating it well. A nice x-ray doesn't necessarily correlate with a great result. We all know that, but I just want to re-emphasize that. Here's my journey over the last 20 years is that plating can lead to some really severe complications and unhappy patients. So I started to drift away from treating these high energy injuries with plates and started going towards X-fix and minimal internal fixation. With that method, I saw three problems. One is my patient said, how can I move my knee with all those wires coming out of my leg? Secondly, infection of the pin sites. And if your pin sites are too close to the joint, you can actually get an intra-articular infection. And the thing that really pushed me over the edge was I actually ran out of fixators. And so as a result, I started putting my patients in calcaneal traction and found out that's a terrible idea because a calcaneal infection is very difficult to treat. And so then I just decided, well, I'm going to put it in the distal tibia, and that has worked well. And I think we've been doing that for at least 10 years. Okay, so this slide is obviously to emphasize that you can have a beautiful looking x-ray, a well-fixed fracture, and a very unhappy patient and their family. And in Ethiopia, there's the usual patient doesn't have insurance, and so a complication is borne by the family, the extended family, and sometimes they just say, I can't, I've run out of money. So an x-ray has nothing. A beautiful x-ray in this patient doesn't mean much, does it? So you should be unhappy as well. So this reviews the complications of surgical treatment and of plateau fractures, the complications, prevalence, and management. So again, let me just move this out of the way. Knee stiffness can occur both in flexion and extension, and both. Chronic infection, acute infection can happen anywhere from 3 to 26%. And the very early studies in the 80s showed even up to 80 to 90% of these high energy injuries became infected. And that's improved over the years, but obviously it is not eliminated. Malunions can occur and are much higher in the elderly, secondary to bone quality. Non-union of these fractures can occur, especially with a double approach and a double plating. And osteoarthritis, either related to the initial injury, inaccurate reduction of the joint surface, or varus and valgus. Deformity can lead to osteoarthritis, leading to ultimately a second operation or just an unhappy patient. And ligamentous instability can occur in a high percentage of these patients. So here's our protocol. One is to place a traction pin 2 to 3 finger breadths above the ankle joint. So you cut the skin just anterior to the fibula. You palpate the fibula, make your stab wound here, and you can see the perineal vessels are sitting right here between the fibula and the tibia. But I've never seen any complication from this approach. Obviously, if you get way too anterior, you can nip the anterior tibial artery. But 2 to 3 finger breadths above the ankle joint, put your knife immediately anterior to the fibula and place your pin on the bone, drive it across, and try to come out straight medially. Put the patient in traction. We just use cement cans filled with various amounts of cement and place traction immediately when the patient is admitted. Elevate the limb and get a CT. Okay, so here's something I think that's wise to do, and that is if you have the ability to get a portable X-ray in traction, either just transport the patient on their hospital cart to the X-ray and leave them in traction with the traction over the end of the bed and see if you have enough traction on. And I think it's wise to actually get a CT scan in traction to see what kind of reduction that you have as well, if it's possible in your institution. Some of you will not have access to a CT in your institution. You can send them out to a neighboring institution to try to get it. I don't think that you should try to handle these without a CT scan. Equipment that's necessary is an access to a CT image. Now, this may be from a town 20, 30 kilometers away, but get CT images. I don't think that you should be doing the treatment that we've talked about unless you have intraoperative C-arm images. You need access to screws and K-wires. And in my opinion, for most of these fractures, I do not personally plate these. So here's our protocol, is to put them in traction, get X-rays to confirm and evaluate the reduction. We either increase or reduce the traction weight based on the portable X-ray, get a CT scan, and then there's the period of waiting to allow your limb swelling to subside. Many of these patients do blister, and you want the soft tissues to be healed. During that time, you can plan your approach or your approaches to that patient. Okay, so on the operating table, if you're doing an anterior or medial or lateral approach, I put the leg flat on the table, especially if there's a posterior fragment that needs to be reduced. Remember, your posterior capsule is only tight if your knee is an extension. If your knee is not an extension, you're not going to get this same ligamentastasis. Some way you need to get the other leg out of the way for your lateral X-rays. Put your internal fixation in at the joint line through stab wounds. And if you have a highly comminuted fracture, you want a lot of hardware that's close to the articular surface. So you can either use 3.5 screws or K-wires to support the articular surface, as well as larger screws. I like to use partially threaded screws and gauge them depending on the size of the fragment that you want to pull into compression. And the other thing that I've learned is you don't necessarily have to use a posterior approach if you have posterior fragments. And that's the rationale behind putting the leg flat. And I've seen some of my residents and partners try to reduce these fragments with the knee flex, and it just doesn't work. So remember, if you have this sort of situation, get the knee in extension and use your posterior capsule to help you out. Experiment on your patients. That's what practice means, right? But try to do it with caution and with a well thought out approach. Again, You can't reduce this fragment using a triangle. It just will not happen. Now you can put traction through here, but it's not gonna pull this back into place. So and lift your other leg out of the way to get the x-rays. And use your collateral ligaments and cruciates to help you gain a reduction. And sometimes you actually have to, and more chronic fractures, you actually have to deform the leg to try to pull these fragments up in place. Now, obviously, remember you've got crucial ligaments, and so these can all help you in terms of reducing your fractures without necessarily having to open them. Now, most of the time, you have to open them to get the final reduction, but you can improve the reduction using the ligaments and their bone attachments. Put the knee flat on the bed to reduce the posterior depressed fracture as it tightens the capsule. And then you can fix these posterior fragments without going posterior just by carefully putting these anterior to posterior screws in, engaging the posterior cortex and pulling them tighter into place. Okay. So the other thing that you need to be aware of is that sometimes it's best to do a posterior approach, especially if you have a neglected fracture and you carefully plan, because these are infrequently used approaches. Obviously, if you're going posterior, you want to protect the neurovascular structures, and so put the foot up on a pillow or use a triangle. You're going to go in and out of traction as a result of this. And if you have the patient prone, then sometimes it's wise to put the opposite leg down along the side of the bed. In other words, push the patient to the side of the bed, let that opposite leg dangle so it's out of the way so you can get a true lateral x-ray with the knee in extension if you need it. These are tricks that I've learned over the years. Final steps. When you're placing your hardware, if you're using stab wounds through a separate approach to place your internal fixation from a lateral to medial side, make sure that your stab wounds are big enough so that you're not dragging skin cells in large quantities into the wound. We've had a couple infections related to these stab wounds, and I think it's because number one, we're trying to get that screw through the smallest incision possible. And be careful that you don't make these incisions too small and you have an infection related to dragging the skin into your wound. Finally, make sure your screws are not too long, especially if you put a screw in from posterolateral to anteromedial. You're not going to see it on x-ray because it's obscured by your medial condyle here. So make sure that you rotate your leg under C-arm so your screws are not too long. That makes the patient and the surgeon unhappy. Place your hardware as posterior and as anterior as you can to help gain compression throughout the knee, and this improves the strength of your fixation. So try to think three-dimensionally, spread your hardware out. Don't just place it 1 centimeter apart, but spread your hardware out if you're going from medial or lateral so that you have compression all the way across the joint surface, and make sure your screws are the appropriate length. So here's a case. Here's the immediate postoperative x-ray with the patient in traction, as you can see. The joint surface is well aligned, and so the surgeon should be happy. And here's our postoperative protocol. You can see we have homemade beds with traction ropes. We move this up and down according to the needs of the patient. And you can see the patients have an anterolateral approach. Looks like the hardware is put in from this direction as well. And on the third postoperative day, we start moving the knee. And so this traction weight does protect your repair. It holds this joint somewhat distracted. You don't want to over distract it, but this actually helps you keep the lower leg aligned. Okay, and so we send them home in traction. We send them home with the instructions to try to approximate the amount of traction that they had in the hospital, and then we see them at 3 weeks. So at 3 days we start moving, and you can see you can get immediately up to 70 to 90 degrees of motion in the hospital. Okay, there's the anterolateral approach. Here's the same patient 3 weeks post-op. You can see he's well aligned. Here's some more cases. Exploded tibia with a corresponding shaft fracture. Really comminuted. Exploded. Subluxed and depressed. Hardware from multiple directions. You see he's in traction in his postoperative x-ray. He's in full extension. And hardware is in multiple directions. There's another patient. Again, widely displaced fracture. Depressed. And he had a posterolateral approach. And you can see the stab wounds here. Patient's in traction with the limb elevated. His leg is straight, but elevated. So his leg, the venous system is emptied in this position. His leg is straight, and he's working on flexion while he's resting in his bed. Hardware placed in the lateral side. Okay, so at this point, you can see we've waited until his blisters healed. And at the time that I was writing this particular PowerPoint, we had the whole 5-bed ward was full. We have multiple rooms. Some of them have 2 beds, 1 bed, 5 beds, 6 beds. We had 5 patients in traction and competing against one another in terms of getting their range of motion back. There's another patient in the next bed. Again, severely depressed fracture. Working on his range of motion. Screws from multiple directions. Anterior, posterior, lateral to medial. This guy's an overachiever. This young man is here for his first post-operative visit. He's been at home in traction. He's got 2 incisions on his medial side of his knee, and he's been in traction at home. We're here to see if he can have his traction pin taken out. We're going to check his stability of his fracture, and it's excellent. His motion just by himself here is about 90 degrees of flexion, and he almost has full extension. So our plan for him is to send him home, take the pin out, and keep him non-weight bearing and see him back again in a month. So at 3 weeks, you need to decide, am I going to continue this patient in traction? And I don't remember ever leaving an attraction for longer than 3 weeks. I think that you can go to a hinge brace if they're unstable. Our hospital doesn't stock hinge braces on a routine basis. They're just too expensive for our patients. So we use plaster splints. I try to avoid this because I think it discourages patients from moving their knee. Some of our patients do drift into varus. They're more varus than valgus. Up to this point, I've not done an osteotomy for a deformity. There are some patients that do go on to a slight malunion. It's up to you when you want to see the patient back, depending on how far they live away from the hospital. And of course, we keep our patients non-weight bearing for a total of 3 months. So you can use a plaster splint, a hinged knee brace, a knee immobilizer, whatever your patients can afford if you don't feel like the fracture is stable enough at 3 weeks. The younger your patient are, the less comminuted they are, the faster that they're going to heal. Why does this protocol work? And I think it works because the dissection of bone and soft tissue is less. It gets the important work done with less damage. Basically, you're restoring the joint congruency, you're repairing the meniscus. If you have a greatly displaced lateral compartment fracture and it's out near the rim, assume that your meniscus is torn and that you're going to need to repair it. We use continued traction, and I believe that this allows the joint to move. It protects your joint repair. And the traction with motion, I think, avoids the stress of the plate fixation, of the metaphyseal diaphyseal interface. Because your joint is distracted and your shaft is basically pulled in the direction that it should be going, you're not causing this undue stress to your fracture. All the forces are in limb alignment, whether it's an extension or it's in the process of being flexed. It continues to maintain its alignment. You avoid dissection of the ligamentous attachments, and you don't bind them up by placing a plate over the top of it. And the timing of the release of traction is strategic because at that point in time, in most patients, if you've avoided these huge incisions and these large subperiosteal dissections, your soft tissues are healing. And the getting your patient in traction early after the injury helps get them out to length. It avoids this unnecessary later dissection. So the immediate traction, getting them out to length, confirming it with x-rays, I think is important because it allows these soft tissues to start healing right from day 2. And removing the traction at 3 weeks allows normal muscle compression of the fractures, and therefore the fracture collapses into and compresses and allows rapid healing. It's the combination of these things that leads to the success of this protocol. Okay, you can also use this for old fractures. Here's a 3-month-old Schatzker 6. Very complex fracture. He's walking with 2 crutches, healthy male. What's documented is decent range of motion at 3 months. Neurovascular is intact, skin is normal, and obviously the patient wants something done. Here's his fracture. I mean, it is displays posteriorly, medially, laterally. It's just exploded and it's malunited. See a shaft here in the center pushing everything out of the way. Small fragments, subluxed. Terrible fracture. And a large piece centrally posteriorly. Again, this was done with limited approaches, limited internal fixation, and distal tibial traction for 3 weeks. Same principles that we use for acute fractures. Obviously, it's a more complex operation. At 3 weeks, he had 0 to 75 degrees. That's the beauty of putting these in traction, is gaining extension is not a problem. Okay, it's you're basically pulling the knee into extension and getting the posterior capsule stretched out. So gaining extension is never a problem. And at 18 months, he had 0 to 130 degrees of motion. Again, I'm not sure if I used the posterior approach on this or not, but his internal fixation is from multiple directions. His joint is restored, his limb alignment is restored. No cane. Okay, final result was good motion, good alignment, good reconstruction, and avoidance of a large complication. So again, here's our first patient that we showed. This is not my patient. This is from the internet. Okay, but basically, this is an unhappy patient, and we should be unhappy with it too. An unhappy patient is a great x-ray with poor motion, either related to poor physical therapy, poor follow-up. An unhappy patient is a great x-ray and an infection that doesn't go away. An unhappy patient is a great initial x-ray, but a non-union, and obviously a destroyed knee that's painful, infected, and stiff. And I've seen those patients, and I'm sure you have too. A happy patient has great motion, a great articular reconstruction, normal limb alignment, no infection, no neurovascular injury, no instability, and no complication. That's the kind of patients we want. I see a happy heart here. Thank you very much.